Focal non-bacterial causes of infectious focal CNS lesion etiology. Um, Neurocysticercosis is the most common cause of parasitic disease of the CNS worldwide. Humans acquire cysticercosis by including food contaminated with the eggs of parasite Taenia solium. Toxoplasmosis is parasitic disease caused by Toxoplasma gondii and acquired from the ingestion of undercooked meat from handling of cat feces. Clinical presentation: the most common manifestation of neurocysticercosis is new onset partial seizures with or without secondary generalization. Cysticerci may develop in the brain parenchyma and cause seizures or focal neurological deficits. When present in the subarachnoid or ventricular spaces, cysticerci can produce increased ICP by interference with CSF flow. Spinal cysticerci may mimic the presentation of intraspinal tumors. When cysticerci first lodge in the brain, they frequently cause little in the way of inflammatory response. As the cyst degenerates, it elicits inflammatory response that may produce clinically as a seizure. Eventually, the cyst dies, a process that may take several years and is typically associated with the resolution of inflammatory response and often abatement of seizures. Primarily, toxoplasma infection is often asymptomatic. However, during this phase, the parasite may spread to the CNS where they become latent. Reactivation of CNS infection is almost exclusively associated with immunocompromised hosts, particularly those with HIV. During this phase, patients present with headache, fever, seizures, and focal neurological deficit. Diagnosis: the lesions of neurocysticercosis are readily visualized by MRI or CT scans. Lesions with viable parasites appear as cystic lesions. The scolex can be visualized on MRI. Lesions may appear as contrast enhancing lesions surrounding by edema. Very early sign of cyst is hypodensity of the vesicular fluid on T2 weighted images when compared with CSF. Parenchymal brain calcifications are the most common findings and evidence that the parasite is no longer viable. MRI findings of toxoplasmosis consist of multiple lesions in the deep white matter, so thalamus, basal ganglia, gray white junction, and cerebral. With contrast administration, majority of these lesions enhance in a ringed, nodular, or homogeneous pattern and are surrounded by edema. In the presence of characteristic neuroimaging abnormalities of T. gondii infection, serum IgG antibody of T. gondii should be obtained, and when positive, the patient should be treated. Treatment: anticonvulsant therapy is initiated when the patient with neurocysticercosis present with the seizures. There is a controversy about whether or not antihelminthic therapy should be given to all patients, and recommendations are based on the stage of the lesion. Cysticerci appearing as cystic lesions in the brain parenchyma with or without pericystic edema in the subarachnoid space or at the convexity of the cerebral hemisphere should be treated with anti-cysticidal therapy. Cysticidal drugs accelerate the destruction of the parasites, resulting in a faster resolution of albendazole and praziquantel are used in the treatment of neurocysticercosis. Approximately 85% of the parenchymal cells are destroyed by single course of albendazole and 75% a single course of praziquantel. The dose of albendazole is 15 mg per kg per day in 2 doses for 8 days. Praziquantel is 50 mg per kg per day for 15 days. Although number of other dosage regimens are also frequently cited, prednisone or dexamethasone is given with anticysticidal therapy to reduce the host inflammatory response of the degenerating parasite. Only cysts in the vesicular stage, where the cysts contain larvae, scolex, and cysts in the colloidal cyst and larva degenerates, are treated with anticysticidal therapy. Some but not all experts recommend anticysticidal therapy for lesions that are in the granular nodular stage. There is universal agreement that calcified lesions do not need to be treated with anticysticidal therapy. Anti-epileptic therapy can be stopped once the CT scan shows resolution of the lesion. Long-term anti-epileptic therapy is not recommended when seizures occur after the resolution of edema and reabsorption of calcification or degeneration cysts. CNS toxoplasmosis is treated with sulfadiazine, combination of sulfadiazine 1.2 to 2 gram orally QID plus pyrimethamine 100 milligram orally to load, and then 75 to 100 milligram orally QD plus folinic acid 10 to 15 milligram orally QD. Folinic acid is added to the regimen to prevent megaloblastic anemia. Their therapy is continued until there is no evidence of active disease on neuroimaging studies, which typically takes at least 6 weeks, and the dose of sulfadiazine is reduced to 2 to 4 gram per day and pyrimethamine to 50 milligram per day. Clindamycin plus pyrimethamine is an alternate therapy for patients who cannot tolerate sulfadiazine, but the combination of pyrimethamine and sulfadiazine is more effective.